This is, again, another patient we had over at Central Maine Orthopedics. This is with a twist. This is a rheumatoid patient. Rheumatoid arthritis can create severe deformity. This side is corrected and was worse than the other side. So I showed this to my dad, and he said, oh, well, how come you can't show the one before? Because I didn't take a picture of the one before. I thought this was good enough, so you just have to trust me that this side was worse. Okay? Finding deformities. All right, arthrodesis, procedures of the foot. Arthro means joint. Desis means fusion. We talked about that, right? Yes? Yes. Everyone knows what arthrodesis is. That's good. Now, I just put in a random potpourri of different types of arthrodesis. Basically, we fuse everything and anything that is arthritic. And some of that can be done without a lot of impact of the foot and the function. And some of it, you know it. So these pictures are basically a lesser tarsal fusion. This is a subtalar joint fusion in a complex way. This is a midfoot fusion in a complex way. This is a subtalar joint fusion in a very classic way. And this is another midfoot fusion. I just wanted to show you guys. So basically, everything can be fused. This is a great toe fusion being done. See, there's a plate and screws going in. Arthrodesis or fusion procedures. Basically, pretty much any joint can be fused within the foot if it is arthritic, excluding the fourth and fifth metatarsal tarsal joint. If you fuse that joint, you are going to have trouble. Trouble, trouble, trouble. So, anyone that does that really does not know what they're doing, because that's a big deal.
What kind of trouble?
Yeah.
Unrelenting pain, inability to walk, major trouble, no accommodation for any kind of uneven ground. It's a big deal. I saw it once. And in addition to that, we never fuse lesser metatarsal phalangeal joints. We'll fuse the great toe, but you're hard-pressed to see one of these being fused. If you guys out there and abroad have seen someone fuse this, I'd like to know about it. Okay. You got it? So really, we can fuse pretty much anything aside from those two entities. Okay? Look at how I made this X.
That's great.
Do you understand? Do you see how artistic I am?
Yeah.
These are identifying the joints you should not fuse. Therefore, I created an X to memorialize it.
The joint bishop would love to.
It's amazing.
You are someone.
It is. It's a big deal, I know. Acquired flat foot. Boom. Adult. There it goes. What's the cause of an acquired flat foot? So you're born and you're thinking, hey, my feet are looking pretty good. And then all of a sudden you get into your 40s and your 50s and your 60s and you're going, something's screwed up. I all of a sudden have one of my feet flat and it hurts on the inside ankle. The cause of flat foot is a chronic inflammatory process of the posterior tibial tendon, which gets inflamed, micro tears, stretches, remodels, and eventually becomes dysfunctional. We all know that tendons are under tension, like the puppet pulling the strings. If the tension is no longer there and the tendon is stretched out, it will not function anymore. There is your tendon of concern, the posterior tibial tendon. If you looked on the inside ankle anatomy, and we didn't do a lot of, or any tendon anatomy, but inside the ankle is Tom, Dick, and Harry. Tom being posterior tibial tendon. Dick being flexor digitorum longus. Harry being flexor hallucis longus. So Tom, Dick, N, artery and nerve. Nice little mnemonic, Tom, Dick, and Harry. Learned that back in the day in anatomy class. So when Tom gets dysfunctional, it's a problem. Conservative care, immobilization for the acute setting, physical therapy to enhance or compensate the muscles that move the foot in, anti-inflammatories, basically orthotics or ankle foot orthotic devices, activity adjustment, or federal disability is all an option. No more on that. Federal disability, yeah. Surgical options. Indications are non-responsive to conservative measures. And really, the surgical options are one of two. You can fuse it, because I told you guys we could fuse anything, except for those two drawings. Or you can try and reconstruct it. And basically what drives fusion versus reconstruction is the presence of adaptive arthritic changes. So if there's no adaptation to the position, if someone didn't neglect it for years on end, you probably could recapture function of the foot in position. This is an example of a very classic approach where the heel bone is cut and repositioned. A graft is placed within the heel to twist the foot back into a normal position. And then there's always some soft tissue work that's also done that usually involves lengthening the Achilles tendon and transferring another tendon, the flexor digitorum longus, to help adjunct that tendon. Kind of complex stuff, but this just shows you how you can recapture some of the anatomy. This is a skeletally immature foot, but you get an idea that the foot on the bottom is basically restored as far as the arch height goes in the architecture. I mean, we're not going to detail all the angles, but you get it. It's not sagging in the middle anymore. So repositional osteotomies can restore architecture and function. You can make it look pretty again. Here's some terminology. This is good for you guys. You guys like this burdensome stuff, right? What does arthro mean?
Joint.
Yes. Arthrodesis.
Fusion of the joint.
Good. Arthroplasty.
Resection of a joint.
Arthrodiastasis.
Distraction of a joint.
Wow.
Aren't we smart?
What's this? Wait, anyone? What about our friends from the hills? Anyone over there? Well, you got an operation tomorrow. This is the boarding. Arthroeresis is an older term which has re-established itself in the past 10, 15 years in the foot and ankle area. And what that is restriction of abnormal motion of a hypermobile joint. Okay, arthroeresis. Yes, there it is. Boom. We're now putting an implant into the foot to restrict the outward motion of the foot to restore the arch. Subtalar joint implants or arthroeresis procedures. Okay, there it is. Usually these are done on younger folk, children beyond 11 and maybe before, I don't know, 25, 30, somewhere in there. But you can see that, this person has pain. This is a flat foot. This is not suitable. And really, we drive the treatment based on the symptoms, but sometimes we question whether that is enough. In other words, when you have a child that has severe deformity that does not have pain, I always ponder, should I just leave them alone because I'll be gone in 30 years from now? And they'll say, yeah, I saw someone, but he never did anything, Or should we be courageous and correct it? Well, I'm very careful with that, and I like the balance that I practice in. I don't correct everyone, but, I kind of try to look towards the future. So, you can see that, this boy's corrected. And, you know, he's here in this community and he's playing hockey now and skating and he's a lot more comfortable. So you go from that, you know, to that. You could see that the position is good and that's one thing. But what's more important is that the function and the comfort is there. And this guy in his 30s and 40s is not going to look back and tell his mom, like, hey, you know, saw this foot here and you didn't do anything about it. You know? So now something's done. And he's good. He'll keep. The implant is shown here. It's simple. I mean, you know, it's probably the simplest thing I do. But we really put an implant between the talus and calcaneus. And that procedure is arthroresis. Very good. We got educated today. Look, this was done in 2011. Amazing. That's me! I love that fish.
Yeah.
It's great. That's him.